Emma, de
Smartphone connected.
Hello.
Hello. Hi, Jamal.
Hello, how are you?
Fine, thank you. So, yeah, sorry
How are
to
you?
miss you in
Yes, Very unfortunate. Yes, we couldn't get
Yeah,
the visa.
yeah, yeah. It's actually I got the visa also about 2 weeks before the
Really.
Congress. Yeah.
Uh,
Yeah,
and
I don't know.
I could not apply for the Argentine visa because my passport was stuck there. So otherwise, I would have attended this meeting.
The same thing, I couldn't go to Argentina either because, for visa for Argentina, it should be 1 month before.
Oh, okay, okay.
And I was in India. So,
Anyway,
yeah.
nice to see you.
Yeah, nice to see you. I hope, and the next one, we will have a good, meeting and also planning, Jamal. Yeah.
Yes, yes.
Mhm.
Should be working.
I'm asking in the chat.
Normally, I'm checking for here. It's working here because I can hear it, but I don't know whether it's working for the.
Are you able to hear us there, Jamal?
Si puede, no sé si se. Okay. Good morning, everybody, and thank you very much for attending both virtually and in person in Buenos Aires. And the goal of this presentation today and this discussion is really to try to get better access to fluorocortisone and to hydrocortisone for children and families present with congenital adrenal hyperplasia around the world. And what we have all come to realize is that there are so many different ways of getting or not getting actually these drugs that are important for the management of this condition. And I think that many of us have been trying to deal with shortages to find very interesting ways of getting the medicine to the patient. And today we have pediatric endocrinologists in the room and attending from all over the world. And we are really meeting with Dr. Kate Armstrong from CLAN, and she will talk about her own ideas, project, and see how we as pediatric endocrinologists can support the project. After all, we are the one who, if we don't see the patients, we usually train the people who are going to see the patient. So I think we play a major role in there. And by unifying and by working together with the families, with government, well, I think that we will have much more success. So I'm talking here in the name of Global Pediatric Endocrinology and Diabetes, so GPED, which is a non-profit organization aiming at improving the care of children with endocrine disorder and diabetes who live in resource-constrained setting. It was founded in 2010 by the late Joseph Orbeck. It is a member of the ICPE, and normally we will have a presentation from Dr. Maya Craig, who just became the chair of the ICPE, which is the International Consortium of Pediatric Endocrine Societies. GPED also presents resources, clinical case discussions, access to medicine, newsletter, and we are trying to support our colleagues around the world. And by one of the things we are doing is by giving or providing medicines when we can do it. It has more than 400 members from more than 50 countries, and this is the website address. Now, access to medicine is a really complex problem, and the more we get into that, the more we understand that it is a complex problem. If we start on the low end, well, you definitely need to have pediatric endocrinologists and allied health professionals in order to, so you need capacity. And I think that all over the world, there has been a marked improvement in capacity in pediatric endocrinology in general. We need facilities and equipment, and we need national and international collaboration, and that we are going to work on that today. But once we have the capacity, well, you also need to have the medicine. The WHO and the national EMLs are working towards promoting and emphasizing the need for the most essential medicines in our system. We have to deal usually with public and private healthcare systems that sometimes go in parallel, sometimes go not so in parallel. We have to distribute the medicines. There is the wholesaler step, there is the pharmacy step. And once we have the availability of the appropriate medicine, we still need the pricing of the medicine to be right. We need national healthcare policies that are going to support this medicine in the country. And there is a huge complexity of national and regional regulatory approval. The pharmaceutical industry plays a major role, of course, because they are the ones who are making these medicines that we need. There is clearly an understanding that the market potential and the business case needs to be present also, and I think this may be an important block for the pharmaceutical industry. Dealing with the national healthcare policies is also sometimes very difficult for the pharmaceutical industry. And finally, and I leave it as the last part, but I'm sure that Dr. Armstrong will put it as the first part, because this is really what CLAN is all about when Kate Armstrong is talking. We need parents group, we need patient knowledge and education, we need advocacy, we need to have the culture of families getting together in order to advocate for their own needs. So we are in South America, and therefore I took one of the papers we published 6 years ago, trying to review well how what is available in the area of congenital adrenal hyperplasia in South America, Central America, and Mexico. And at the time, and it was only 6 years ago, you can see that most countries had, well, all countries had on the national list hydrocortisone, prednisone, or prednisolone. Hydrocortisone IV or IM is also very, very commonly present. And fludrocortisone was only present on the national list in 48% of the countries, despite having been added to the WHO EML in more than 10 years ago, around 2009, if I'm correct. So the fact that WHO proposes and recommends specific medicine is one thing. The fact that it is on the national list is a second step. But once it is on the national list, the fact that it is actually available to the country, up to the patients in the country, is a third step, and this is much more difficult to identify. What you see also is that the richest countries, and this is on the x-axis, the gross national income, the richer the country, well, the number in the national, the higher the number of medicine present in the national EML. That's not very, very surprising. Richer country will have the capability of adding more medicines than poorer countries. Now, when you see, and we are going to hear from several of our colleagues, but specifically in South and Central America and Mexico, the access strategy is very, very variable from one country to another country. There is an adaptation to the local situation. First, the medicine is sometimes registered, sometimes not registered in the countries. Sometimes it depends on a local manufacturer or a local distributor. Sometimes it depends on international pharmaceutical companies. Very often also there is smuggling, and I don't say this is in a negative way, but smuggling through the border of the medicines, through family, through drivers, truck drivers, for example, between Spain and Morocco. It's not in South America, but this is an example. Friends and family ship the medicine, or there is simply no access. And I know that I got a call from Bolivia recently saying that they really didn't have a way of getting the medicine, the hydrocortisone in the country. Now, I also did, like 6 years ago, an estimate of the annual fludrocortisone needs in South and Central America and Mexico. It's just based on the theoretical prevalence of CAH and, of course, of Addison disease, the other situation where you need fludrocortisone in endocrinology. And the estimate was that in needed more than 8 million tablets of 0.1 milligram of fluorocortisone. And when I talk to my colleagues in the continent, based on the perceived needs in 2020, so based on the known patients, this is still about 2 million tablets, more than 2 million tablets that are needed. As usual, patients, when they are known, need the medicines. When the medicine becomes available, the number of diagnosed patients becomes higher. So there is clearly a need of several millions of tablets on an annual basis, but split between a large number of countries. So in summary, access to medicine is a complex issue, and pediatric endocrinologists play a pivotal role in the clinical care of the children and the family, in training health professionals, in providing data to identify the needs, and also in advocating at the level of the government, advocating for the patients. And today we are meeting to discuss issues around access to medicines that are common to all pediatric endocrinologists in different settings. We're going to hear from Paho from the Pan American Health Organization section of the WHO, what they do in order to support access of medicine in Latin America in general. And we will see that this is a very, very interesting approach that they have taken. I believe this is the only section of the WHO to do that. We'll understand the CH at MAIDS for Kids movement that has been initiated by CLAN, by Dr. Kate Armstrong. And we'll propose concrete measures by which GPED and ICPE can engage in the CH and MAIDS for Kids movement and work together with CLAN and this movement. So we have some work to do, but we'll see that the understanding what the situation is really very, very interesting and eye-opening in the first place. And I think this is the first time that we try to be together around the same table and see what are our differences and common issues. After that, I have the draft here. We will first hear from Dr. Kate Armstrong to explain what her goal is, what came up, what prompted the initiation of this CAH and MAIDS for Kids project. And after that, we'll hear from Maria Craig, who is the new chair of the ICPE, of the International Consortium of Pediatric Endocrinologists. Share experience from the Americas, and we have Sir Elvin Morla from the Dominican Republic and Raul Calzada from Mexico. We'll have Dr. Lim, who is a guest speaker from PAHO, who will really report on what PAHO is doing. And we have several colleagues, either remotely or in person, such as Dr. Salwa Musa from Sudan, who are going to present the situation in their country. We'll hear about difficulties, but also about successes, as you will hear from Pakistan and Zimbabwe. And after that, we will just go into discussion and try to see how we can create some working group that will really take a global approach in order to improve the access to medicine. So, without further ado, I will ask Kate to take over and present the CH and MAIDS for Kids project.
Thank you very much, Jenny. Are people able to see the screen there? Just going to update the screen on the just going to update the screen on the Thank you very much, JP, for getting us started there. Can everybody online hear okay? Diane is monitoring here online as well, so if we have any problems, Thanks for setting the scene, JP, and thank you very much to everyone who's joining here in the room and also online all around the world. It's exciting to have you all here today. We're proposing something called a big, hairy, audacious goal. We're wanting to do something really, we're wanting a step change between now and 2030. And I'm going to talk about with you today, the what, the why, the how, the where, the when, and the who. I'd just like to start by acknowledging I'm an Australian, and I'm not sure why I'm here, but I'm glad I am. And thank you to the IMPE team for inviting me here. And I'd like to acknowledge the traditional owners of beautiful Buenos here. I had a chance to walk around yesterday, it was lovely. And I'd also like to acknowledge all of the wonderful people Glenn's had the opportunity to work with over the last almost 20 years in the field of pediatric endocrinology. Looking forward to getting to know you all better. I don't think the slides are changing for everybody. We're just going to try and change the slides for everybody online. So what we're proposing to do is to link in with the UN agenda of achieving the SDGs by 2030. So there are 17 Sustainable Development Goals and SDGs. And SDGs like this. So, okay, so I'll just try and, is that changing the slides online now? Okay, so we're trying to achieve SDG 3.4, reducing the mortality associated with CAH by 30% by 2030. We know that children with CAH don't need to die. In Australia, America, high-income countries, children with CAH don't die. And I'd like to acknowledge that I'm speaking as the mother of a young person with CAH who's living a very good life, but also as a clinician, as a public health physician, and as the founder of Plan. So looking at this, I acknowledge through a few different lenses. In low-income countries, we know that children are dying. Just trying to, there's two different lenses, sorry. Just don't know what to do. Thank you. So, Plan has been working in the Asia Pacific region for the last 20 years with a number of countries, and we'll hear people telling their stories today. And using this strategic framework for action that really focuses on things that families say they want. And affordable access to medicines is always the number one thing that families say that they want. So you have two events now. So in terms of the proof of concept, things have changed dramatically in Vietnam. When we started, there were about 100 children, and now there are several thousand children in Vietnam. And mortality in Vietnam now is quite low. Likewise, Aman and Jamal will be talking about their experiences in Pakistan and Indonesia. But we also know this model is replicated for other conditions. So not just CAH, we've been working with osteogenesis imperfecta, type 1 diabetes, but also my doctoral thesis was in nephrotic syndrome as well. Pediatric endocrinologists have a vital role to play. I use this image of superheroes. We published a paper in 2020. We wouldn't be able to do the work that we do without pediatric endocrinologists. In the work that we do with nephrotic syndrome, we need to work with pediatric nephrologists. But if we want to do something in the field of endocrinology, we really need pediatric endocrinologists. They're vital to play. In 2015, we worked with pediatricians in Pakistan. At that stage, there was no Pediatric Endocrinology Society in Pakistan. And we spoke about the situation for families, and we reflected on the 5 things that they said that they wanted: affordable access to medicine, education, research and advocacy, optimal medical management, strong support groups, and freedom from poverty, and talked about what systems and structures were in place in Pakistan to help with that. So did they have access to the medicines they need? Did they have newborn screening? Did they have educational resources? Did they have support groups? Were the children going to school? And we were able to come up with a score, a quantitative equity scorecard that would give us an idea of the situation. And obviously, as JP has mentioned, the situation is very different in high-income countries and low-income countries, as you can see. When we asked the pediatric endocrinologists, not just in Pakistan, but we also then talked with doctors from around the Asia Pacific about what they need. Interestingly, access to medicine came up as the #1 priority, and CAH was routinely a high priority for them as well. So there's an urgent need to scale. We've been doing some work in the Asia Pacific, but in 2021, Clan heard from doctors in Zimbabwe, and they were experiencing the same situation. By that stage, the team in Pakistan were manufacturing locally hydrocortisone and fludrocortisone, and we've been exporting and importing from Pakistan to Zimbabwe, and the CAH community there is growing stronger. But how could we scale action? Instead of drip feeding from one country to another, how can we do it globally and take it to scale? We wrote up a briefing paper. We have a copy of it here, and we've sent a copy to everyone. We prepared it for WHO in February 2022, and we really looked at, we laid out a plan for how we feel that we can contribute to the SDGs by 2023. And we can reduce mortality with CAH in 3 ways. We can increase access to medicines, we can scale newborn screening, and we can strengthen communities, CAH communities, using the framework that Clan's been using. We're going to need some guiding principles. We're going to need to focus on a human rights-based approach, an equity focus, community development. There's a number of different principles we outlined there in the briefing paper, but also using a critical action community and practice approach. This is the knowledge to action framework. What that does is focuses on identifying the problem really clearly, identifying local solutions, coming together, choosing some actions that we're going to do, monitor the outcomes, and evaluate it over time, share and disseminate. So we would come together as a community of practice and work together. And today we're going to hear some success stories, but continue to share our stories, because there's a lot of, even today, we're learning about new fludrocortisone that's available in different countries. There are other frameworks that we can use. The Ottawa Charter is one, for example. But PAHO is going to talk to us today about their market shaping and the way they do demand. They influence demand and supply. And I acknowledge that since first we met with PAHO a few weeks ago, and since listening to them and learning about their model, we've started thinking about what does this look like potentially for Mates for Kids. How do we increase the demand? Obviously that means getting families to some children to survive. but also then how do we strengthen supply chains as well. We can learn from what we did in the Asia Pacific about looking at an equity scorecard, so doing some rapid snapshots in different countries around the world and coming up with an equity score. This is a score that Australia would get. We would score 27 out of 30 if you look at all the structures and systems to support people living with CAH. But some of our colleagues in Africa at the moment are probably scoring about 12 out of 30. This really prompts local champions to identify some priorities and opportunities for action. And we can talk about the indicators in a little bit more detail later on today and moving forward, but I just want to show that we have it written down here and people can look at it. It's also in the papers shared online. What those indicators that we've proposed are, but within the community of practice, that's something we talk about. So we've talked about the what, the why, and the how, just briefly on the where. So wanting to acknowledge that there are 6 WHO regions around the world. We have all 6 regions represented in this meeting, and the World Bank ranks the countries as low income, high income. We're not so much interested in the high income countries. We're only really interested in the low middle, and the low middle income countries. Some regions like Africa have a lot of those, whereas when you get to the Americas and particularly to the European region, there's a lot more countries that are in the high income. But if we look at all of those 6 regions and we say, okay, we go from about 190 countries globally down to 132 in the low, middle, upper middle rankings, then if we're going to reduce by 30% by 2030, and these are just rough numbers, but if we made a change in 30% of those 132 countries, we're looking at about 40 countries that we need to work in over the next 7 years. We need to take a phased approach. We need each region to identify a couple of countries each year that they wanted to start working together in. We've already been working in Zimbabwe, and the African region has already identified countries that they would like to work on, for example. But if we do this and also leverage key events that we could all come together to discuss things, as well as the community of practice meetings, then we have the opportunity to share successes and work together. So today we're going to hear stories from around the different countries, different people who are involved, but then we'd really like to open it up and talk about how do we want to work together moving forward? Do we want to work together moving forward in a really strategic way with some tight timelines and really hold ourselves accountable to try and make a difference? Thank you, JP. Sorry for the technical issues, everybody.
Thank you very much, Kate. This is really a nice description of plan, and again, a call for understanding how pediatric endocrinologists first can work together, but also can support such a broad initiative that we know is definitely needed. I'd like to invite Dr. Maria Clay to present on ICPE. I think this is very timely. The ICPE is an international consortium for pediatric endocrinology, and Maria is just the incoming president of this association, and this is really a step towards the collaboration and increasing the collaboration of all pediatric endocrinology around the world. And Maria.
Sorry. Apologies, I don't have any slides, but that's probably a good thing because it's save the technical issues. As JP just said, I'm about to take over as the president of this organisation that represents paediatric endocrine societies across the world, including obviously SLEP, who was the host for the current meeting, as well as SBE, APIS, which I'm the Asian Pacific Society, which I'm the Australian New Zealand Society, many others. The IMPE came together, I think, really more as a trying to improve communication across the societies and also support the organisation of the meeting of joint societies that occurs every 4 years. But I think the reality is that it could do much more. And, listening to Kate speak, and obviously I've known Kate for more than 15 years and seen the amazing work she's done. I think working with IMPE to really discuss how we can do more to support the efforts of maintenance for kids, the answer to what I've been asked about. We've had Kate present at a number of sessions at, say, for instance, the APIS meeting or even a local departmental meeting. And every time there's a presentation, such as the one just now, that highlights many of the inequities, inadequacies, and opportunities, somebody puts up their hand. So I think, for instance, even Kate just speaking of things, the meeting is a way to really increase awareness. I think there's a very large number of pediatrics across the world who have absolutely no idea. That talk about several times and it's getting into my head. But there is so much that we can do as a society if we increase awareness. From a practical point of view, within APIS, we used to have a working group with a plan, and we were hoping to reinvigorate that. But I think this should be on the agenda. Obviously, there's many diseases, but because there's already such an armamentarium that's way. I'd like to be able to see this. Obviously, GP is also, but the benefit is that it gives it's all organisations together. So I think there's many more important people to speak than me. I think that really the critical issue is just being aware that we're an organisation that we can reach out to not only paediatric endocrinologists, but also and these societies do have links to healthcare policy and government. So, yeah, thank you.
Thank you, Maria, and for this presentation. So the first three presentations were really about understanding that, well, pediatric endocrinology, we actually know each other quite well around the world, and I think that both CLAN, ICP, and GPED really find almost every single pediatric endocrinology in the world, and I think that we are always very open to collaborate. So let's try to see whether we can do that for this particular very important topic. In a country like Canada, fluorocortisone is something that is so affordable. We don't even think that it could not be available. And still, in many other countries, it is considered something not only difficult to handle, but when it is available, sometimes it costs 5 to 10 times more than it would cost in a higher income country. So I think that before having a large discussion and understanding how we could work together specifically and identify champions, I want to hear about the situations in very specific countries. And I would like to introduce the first two speakers. The first speaker is Professor Elmi Morla from the Dominican Republic. And we have collaborated together, actually, GPED and the PES in North America have developed in Result France in Costa Rica a course, and that was quite successful, first in person, then remotely because of COVID. So we know each other very well, and I think that the experience that Dr. Morla has in the Dominican Republic in getting the fluorocortisone and the hydrocortisone present, how sustainable it is, well, that's what we would like to hear from you, actually.
Okay. Thank you. I will appreciate this invitation. I'm sorry because my slides are in Spanish. GP was the responsible because he didn't tell me that it should be the English. So
I said we were all collaborating and very nice to each other, but there we are here.
Okay. I will show you briefly the experience that we have in the Dominican Republic Dominican Republic is part of an island in the Caribbean, like Hispaniola. You know. We have a special condition is that, especially in the south of the country, it's very rich in metabolic congenital disease, such as 5-alpha reductase and obviously congenital hyperplasia. We have 3 children hospitals, but we concentrate this patient in the principal hospital, you know, for a long time. Well, this is the group of patient, you know, this is the sex, female, more than female than male. This is different age. As you see, we have different age. The problem is that some of these patients were followed in another area, but after they were transferred to the hospital. You are supposed to have autism in the first group. We had 128 patients registered. 31 with karyotype AKDS, almost all female. Patient with congenital ambiguous genital. It's very important for us because we are especially clinical. The identification of this patient, as you will see later, it's especially clinical condition. You know? Then we have 53 patients with ambiguous genitals. And as we know, the principal reason for ambiguous genital is congenital hyperplasia. This is what we are able to do, electrolyto and 17-hydroxyprogesterone. Electrolyto, as you know, be normal or not, depending on the condition of the patient. And the concentration of 17-hydroxyprogesterone in relation to the age of the patient. Those are the medicine that we have in the Dominican Republic. Fluorocortisone, always. We are rich because we are offering had fluorocortisone. I remember that when in the United States I had problem with fluorocortisone and we had a lot of fluorocortisone in the Dominican Republic. Glucocorticoids, we use methylprednisolone, prednisone. We have problem with the desamethasone. I don't know what happened. We hate the desamethasone because even using small dose, the patient usually may stria. And all the patient had hydrocortisone parenteral. During all this time, you know, more than 100 patients, we only had 1 die. We usually work with mortality 0. The patient know what to do at home. The patient that died was because they moved from one city from another without the medicine for several weeks, plus infection was impossible. We do not get hydrocortisone anymore. This is not a problem because we resolve with another glucocorticoid. These are the difficulties in the program. First, fluorocortisone and hydrocortisone has not been registered in the country. At the beginning, we made a meeting with the 2 principal pharmacies. I know that in other part of the world, they have fluorocortisone and hydrocortisone. I remember that by this time, Pfizer have hydrocortisone. They told us that was not possible to change the medicine from South America, from Central America and the Caribbean, because you know it's our area. That's a full answer, you know, that he can make this medicine from one place for another. Then despite the two principal medicines have not been registered, we get the fluorocortisone that is the principal headache in this problem is fluorocortisone. We need a special letter from the public health to give to the pharmacy, that the pharmacy get the medicine out of the country. Usually, one of the pharmacies get the medicine from the United States. Actually, the one that we have say that come from Argentina. Let's say come from Argentina. Other of the problem is that the change in the different government, you know, then the new government do not know how much the mechanisms to get the medicine. They think that we are working bad. You know, when we came, the authority, the new authority think that the lax authority were working bad. That's true. There is no possibility in trying to get genetic molecular. That will be very important for us to get the final diagnosis of this patient. And another big problem is the transfer of the patient from adolescent to adult. It is stated this big problem with the adult endocrinology. That's all. Some for the attention.
Thank you very, very much for this presentation. And I think we may keep questions for after that because there will be more presentations. But I would like to highlight several very important points that you have made. One that was indirect, the ratio of boys to girls is way higher for girls than for boys, and it should be equal in theory for and this tells us that it's very common when the screening is not available. And this is the case for many countries. We have not talked about that, but I know that this is also something that Kate has already in her mind, and probably a much more difficult thing to and complex thing to achieve. But clearly, your data are very consistent to
yes,
many other
we know that. We know that. When you have the screening, the relation is similar.
Yeah.
But we lost some. The problem is that the diagnosis delay. That's the problem. And some of them die by another condition that the pediatrician forget.
Yeah,
you know that.
So yes, absolutely, and so that's a very important point. The second thing is that you have given us an example where you seem to be getting the fluorocortisone regularly, actually from Argentina, which I didn't know, but the medicine is not registered in the country, and that's one of the each country seems to be different. You have talked to a international pharmaceutical company that tells you that they can't send it there. For a clinician, it's very difficult to understand why a pharmaceutical company cannot send a pill from one country to another country. I suspect that maybe the registration in a smaller country would be difficult for not interesting from a business point of view. That's maybe one of the explanations for an international pharmaceutical company.
Do you know what happened? At the beginning, one of the pharmacy registered the tooth medicine, but the supplier out of the country told the pharmacy, you are buying 2 liters. We need that you buy us too much medicine. And the pharmacy said it's impossible for us because we have a small Bluetooth patient, and they cut. And by this, since that time, is that we have a special letter to get the medicine.
That will be getting very, very nicely into the presentation by Dr. Lim from PAHO, but before who has talk about procurement and indeed situations where each country does not have enough critical demand in order to be fulfilled for a specific by a specific company. So maybe I would like to have a second example from Central America or Mexico, and from Dr. Raul Calzada from Mexico City in Mexico to talk about the situation in this country. And I think we will see, if I remember, that it's quite different from the one in the Dominican Republic. Okay. Thank you, Raul.
Thank you for inviting me to this forum. So the incidence of 21 hydroxylase deficiency is very high. And this is what happened in my institute, the National Institute for Pediatrics. We have 64% of females in the detected by the neonatal screening. We cover more than 95% of the population of Mexico. The soil wasting forms are higher than the sample analyzing. The reason for consultation is neonatal screening results in most of the patients. And however, around 20 to 27% debut with adrenal crisis. However, the neonatal screening is done. The patients don't go to the medical as soon as we like to do that, most of because of the distance between the local home from the cities. So in the official basic medication charts in Mexico, there are dexamethasone, prednisone, hydrocortisone, and fluorocortisone. We don't have problem with this medication in the legal part, but there is a practical problem with the supplies. We have hydrocortisone. Intravenous hydrocortisone is relatively easy to get in all hospitals. But tablets with hydrocortisones, there are not in Mexico. No one tablet is available. So we try to administer with oral parenteral hydrocortisone in most younger people with good results, but this is not the best. And we have prednisolone, which we use a lot. Most of the patients are treated with prednisolone because the suspension permits us to graduate the dose very, very, very easy. And in the late, more than 4 years old people, we change to a prednisolone tablets. We use the lowest possible doses to cover glucocorticoid needs to avoid iatrogenic hypercortisolism. And most of the patients are treated with 1/3 of the doses in the morning and 2/3 in the evening because this is the best way to block ACTH secretion and avoid hyperandrogenism when we use prednisolone. But the fluorocortisone is not sold in Mexico, not even for the government, but no one drugstore sold fluorocortisone. So in the first year, we use sodium chloride, no more than 3 grams per day, because if not, hypertension appears. And we cannot acquire by legal government tender. It's occasional inter-level care hospitals. It's legal import from USA or Canada or Europe. And the people buy online from Canada, the price they get is 300 higher than the cost in Canada. And they get it in United States because 1/3 of the population are some relatives living in the United States. So they buy in the United States and send by illegal methods to the people. So hydrocortisone tablets and fluorocortisone acquisition is very easy, but it's very complex. The first is that the drug must be approved for one or more specific indication. It has done since more than 25 years ago. Then it needs to be in the basic chart of medicine, which has been done. Is considered as essential drug. And then we need to justify the use, which has been done more than 25 years ago. Then we need the acquisition approval. And in this moment, there need to be a national tender. No one offer for national tender because we have not distribution in Mexico. So we need to spur until the second national tender end. We begin this in March. Then the second national tender is in June. As nobody offered it, we need to an international tender would start in September every year. Nobody offered because, as in the Republic, the amount of tablet is not sufficient to interest some pharmaceuticals. And as nobody offered it, we need a special authorization for direct purchase. The logical is to get it and then to enter it. But the reality is that in this moment, in the authorization for special direct purchase, we receive and only that we are sorry, but there is not more budget in the government. So we need to begin again the next week, the next year, with the first drug approval for one or more specific. And there is a vicious circle in which nobody offered and we cannot get it. And the next year we begin again. It's like more than 25 years ago, it's the same. Every year. So it's difficult to speak with the government. As it has been told, we have hydrocortisone. We don't have hydrocortisone by oral administration. We have prednisolone and prednisone, and we don't have fluorocortisone as well as most of the countries of Latin America. What is the cause of the shortage? This is lack of interest in the cell pharmaceutical laboratory due to limited contribution. There is lack of interest from the health authorities because they don't consider that congenital adrenal hyperplasia is a public health problem. Its lack of user demand is limited for non-priority government budgets, and it has inadequate supervision by international. So access to health system in Mexico is mixed. There is unequal social and health security, and there is a selective national health program. For example, 6 years ago, the priority was Turner syndrome because one of the sister of the wife of the president has Turner syndrome, but not congenital adrenal hyperplasia. We need a politician with that song with a congenital adrenal hyperplasia. So legally, everyone has the same right, but not all have the same coverage. And as we are all the same, but not all the same are the same. So the poor people has problems to get it. And this is a fact. 2 years ago, we got from Canada more than 1 million of tablets. They arrived to Mexico, and we cannot recover it from the health authorities because they think it will be sold to the patients. Need to sign a lot of papers, and we don't get the donation. It's really difficult to understand that, but it's the reality.
Thank you very much, Raul, for eye-opening situation. And so this is not, I mean, you have really shown examples of the difficulties at the level of the health authorities. Also, despite the fact that Mexico has 150 million people or more, so you would think that there is a market there, even though it's a small number of tablets that are not expensive, still there is little interest from international pharmaceutical companies. So I think it really shows the first slide I showed with the complexity of the access to medicine in many countries and the different ways that people are getting or not getting the medicine. So the meeting today was not specifically on South America, Central America, and Mexico, but because we have the opportunity of having Dr. Lim from Paro, I thought I wanted to start with two presentations from Dr. Elby and Dr. Calzada in order to set up the scene. So it's very interesting. I didn't know actually that Canada was providing online fludrocortisone. We actually are not making in Canada fludrocortisone. We are importing it also. And it's one that supposedly has to be refrigerated. We have to keep it at 4 degrees for reasons that I'm not too clear on, but I mean, that's the way it is. So that's interesting. Maybe you get a different one when you order online than the one we get in the pharmacies. I just don't know. It costs in Canada about 20 US cents per tablet, something like that. Yes, for 100 microgram of fludrocortisone. So I think this is Jamal. Hi, Jamal.
Hi, how are you?
We have Dr. Lim online. And so Dr. Lim is has kindly accepted to talk to us from PAHO, who is the Chief of Strategic Fund for Public Health Supplies and Health Support at PAHO, the Pan American Health Organization. And Dr. Lim, can you hear us?
Morning, buenos dias.
Hi, Chris,
can you hear me?
How are you doing? Thank you so much for being with us today. And so I hope you have enjoyed the presentations by Dr. Calzada and Dr. Elby.
Definitely. And I think I've seen many very relatable, I think, experiences and problems that they are facing. And I truly hope, first of all, I really wish I was there. I could have interacted with both delegates from Mexico and Dominican Republic, because I think there are definitely a lot of alliances and collaboration we could have done. But unfortunately, I wasn't able to make it. But I'm sure we can interact offline thereafter. So do you want me to start the presentation now, or do we
Please,
have?
would you maybe have any questions for the first two speakers that you would like to clarify before starting your presentation, or would you like to go into it and see after that? What would you prefer?
Sure. No, I think let me just run through the presentation, and I'm sure we would have some, I guess, question and answers, and then we could probably take it from there.
Thank you.
If that works. All right. Great. Thanks. So once again, my name is Christopher Lim. I'm the chief of the PAHO Strategic Fund, based out of Washington, D.C. And let me just move ahead. Right. So first and foremost, for those of you who do not know PAHO, so PAHO stands for Pan American Health Organization. So we are the regional arm of WHO that's looking after the Latin American and the Caribbean region. So PAHO Strategic Fund was first incepted in year 2000. So we have got a history of 22 years ahead of us right now. And I just want to stress, this is our mission statement, which is to improve accessibility, affordability, and availability to quality assured, right? So I think the other thing that we want to really stress is the quality. I think we've heard, speakers talked about the lack of availability and affordability. That's one thing, but I think also in our region, we are seeing a lot of rampant, falsified and substandard medicines. So I think quality assurance is also the other key. And of course, it's essentially to provide public health supplies, which includes not just medicines, but also health supplies to the region. So to date, we have got 54 participating entities, which includes 35 member states and 19 health agencies, and this includes social securities within the region. And some countries actually even involve their police, the army, and the other public health institutions like cancer institutions and so on and so forth participating with us. And over just the last 4 years alone, from 2018 to 2022, we have supported over 118 million people in the region through a procurement of close to about $800 million of procurement itself. So I'll just I hope this video works, but I think it's a good video that actually helps to summarize and and illustrate, right, the value propositions of the strategic fund. So let me know if it doesn't work, the sound, especially the audio.
Did you know that 1/3 of health budgets are used to purchase medicines? High costs, insufficient quality, and hard-to-source products in the market are major barriers to access medicines and threaten the sustainability of the system. For this reason, and at the request of the countries of the Americas, the Pan American Health Organization in 2000 created the Strategic Fund. The fund is a mechanism for pooled procurement of quality medicines and public health supplies. It pools the demand of multiple countries, executes international tenders, and achieves reduced prices when purchasing large volumes of the same product. It also supports countries to improve demand planning and prevent stockouts of medicines and health supplies. What products can be purchased? More than 250, from treatments for various diseases, communicable diseases, non-communicable diseases, and neglected diseases, to medical devices, supplies, and diagnostic kits. The Strategic Fund provides lines of credit for countries when needed through its capital account. The use of the fund allows savings in health budgets. In just 1 year, one country saved $13 million in the procurement of medicines for HIV/AIDS and tuberculosis. All products procured through the Strategic Fund are safe, effective, and quality assured. To use the fund, countries through their ministries of health need to sign an agreement with PAHO. Why do this? Because improving access to medicines and supplies is key to guaranteeing health for all, everywhere. To learn more, visit www.paho.org.
All right, so I hope that gave you a quick glimpse into some of the value propositions and how we work in the strategic fund itself. And just want to illustrate, I guess, reinforce some of the pillars, right, is access, right? So I'll illustrate that a little bit further in terms of how we actually ensure increase in terms of access through a number of strategies like rational selection and rational use of medicines, alignment of treatment protocols, and then quality. So as I mentioned earlier on, right, I think quality is of utmost importance for us as well, making sure that the suppliers and the medicines that we procure on behalf of member states meets the highest quality of WHO pre-qualification. Excuse me. And also, standards around the SRAs, like the stringent regulatory authorities within around the world. And we've got 8 reference national authorities of reference within Latin America itself, like Mexico is definitely one of those COFAPRIs that we work with, and then Visa in Brazil, and so on and so forth, right? So there are 8 of them in the region. And then from affordability standpoint, as you could see, really part of our mechanism is pool procurement, right? So it's pooling of demands across the entire region itself before we go for international tendering. So that economy of scale is really something to be leveraged on. Solidarity, we promote a lot of South-South collaboration, and also loans and donation. We facilitate loans and donations across the different countries within the region itself. And sustainability, we'll talk a little bit about that later on, in terms of us also at the same time, right, building capacity with member states, especially in some technical areas like regulatory authorities and also supply chain management. And I would say this is really one of the unique feature within the Strategic Fund itself, right, is the availability of an interest-free loan, right, that actually facilitate cash flow movements within member states itself. So, i.e., all member states that signs on with the Strategic Fund actually has access into a credit loans, which is interest-free, all right, that actually helps to facilitate cash flows. Now, as you saw earlier on, these are our portfolios. So we help member states with access to medicines for both communicable, non-communicable, and especially this part of the world, right, neglected tropical disease. And then medical supplies like diagnostic kits, equipments, right, and then vector controls for vector transmitted diseases like malaria and so on and so forth. So insecticides and bed nets. And of course, a new pillar for COVID-19 itself. Now this slide it's complex. It looks really busy, and it's really meant that way, right? It's an illustration or attempt to illustrate how complex the whole pharma supply chain is. You know, getting medicines and health technologies from one end of the spectrum, which is the suppliers, all the way to the point of use, right? The arms and mouth of patients itself. As you could see, it's a whole convolution of different elements that's involved. And then those circled in green are essentially areas which food procurement traditionally has done well. And I think they've done a great job there, right? Especially in terms of, tendering process itself, supply management, contract management, ensuring good manufacturing practices of suppliers. To the other spectrum, all right, which is marked in yellow, right, are areas which traditionally they have not done well, but there's definitely important elements there that needs to be improved upon. Like, for example, rational selection and use of medicines and health technologies. And we've heard also around, ensuring that there is alignment in terms of the essential medicines list at the national level, and then, of course, the whole differentiation between adults EMLs and also pediatric EMLs and so on and so forth, right? So there's a lot of other elements that needs to be improved, all right, and be synergized, right, into a very symbiotic relation. All right, so I've seen this slide being leveraged earlier on, which is great, right? I think this is almost a bedrock of that helps to illustrate the work, the market shaping work that we do at the Stream Fund here. So first, I'll talk about the demand shaping side of things. The Stream Fund is actually uniquely poised, right, in the sense that we have very skilled, very detailed technical specialists in all therapeutic areas within PAHU itself. So we work with this technical specialists to understand the various epidemiological situation of different diseases, which could be, malaria, HIV, and so on and so forth, all the way to NCDs of oncology, cardiovascular, and of course, endology as well, right? So to understand really what is the epidemiological situation there, and that information is helpful to help us inform, what is the expected demand going to look like from countries to countries, from within the countries even, right? Provinces, states, and so on and so forth. So what does it look like? But again, knowing the prevalence and incidence rates is not good enough. We also work with the national agencies to understand what sort of protocols are they using, which very often could be outdated, and they are probably also sometimes not aligned or harmonized to the WHO's recommendation. All right, and worse, even worse, right? In bigger countries, and I'm sure Mexico would appreciate that as well, that we've seen also in especially federated countries like Argentina. You guys are in Argentina, right? So Brazil, where we actually observe that there are different treatment protocols in states, in the various states or provinces of those countries, and it obviously needs to be and can be harmonized, and that's part of the work that we do. And after that, we make sure that we also help them to update. So we work with the regulatory authorities, right, like the COFEPRIS and ANVISA and METS, all right, FDAs, to make sure that the protocols are aligned to the national EML list, right, so that can actually facilitate importation, prescriptions, and also dispensing as well. The other part that we work with from a demand shaping side, right, is also we look at the intellectual property landscape of the different medicines and health technologies. So advising countries in terms of, what are some of the possible options in relation, right, to intellectual property? Could they be utilizing like the TRIPS or the Doha agreements, right, enforcing both voluntary or compulsory licensing? And then rational selection, that's kind of like it's related to this treatment protocol, making sure that we align or be able to align or streamline, right, the selection of the use of the medicines itself. And later on, I'll show you one example that we did for the anti-hypertension initiative, right, where we actually help countries, in fact, it's the whole region, right, to reduce the protocol and the treatment selection of medicines itself, right, from 50 molecules down to 8 molecules, right? So just imagine what sort of effect it can have from a consolidation or demand standpoint. And that obviously would help with the economy of scale and bring down, I think, what we have all collectively seen, right? The biggest problem around access to medicine, which is the cost. So with the economy of scale, that really would help to bring down the cost itself, the cost element. Now, so that was the supply shaping side of things. At the same time, we move into the, we were seeing the demand shaping side of things. Now we move into the supply shaping side of things, right? So we have specialists, right? Category specialists that constantly look at the supply landscape. So what that means is looking at and understanding which are the emerging suppliers, right? Who are the suppliers that's up and coming? What sort of technical capabilities they have, their performance standards, and so on and so forth. And of course, at the same time, making sure that they do meet the necessary quality assurance, like good GMP. They are registered in one of their, regulatory authorities of reference. And we utilize a lot of technologies these days, right? Technologies like web scraping, artificial intelligence, robotics, to understand what is the pricing landscape across the world. All right. So we actually automatically use the web scraping technologies to download price points from around the world, and that would actually help to inform us in terms of how we could actually better negotiate. All right. So these are some of the technologies we've actually applied. Now, from a supply chain management, supply relationship management standpoint, so we work very closely with strategic suppliers and manufacturers so that we could actually co-create and in fact co-implement innovations, right? So some new innovative technologies like, for example, RFIDs, blockchains, right, to help traceability and stuff like that. And also new concepts like, for example, vendor management inventory, VMIs. So we actually work very closely with strategic partners, right, to co-implement and co-create and implement, right, this sort of innovations. And the last piece is really around supply resilience. As we have seen in the last couple of years, right, that the whole world essentially were kind of like really just relying on a couple of countries from a production standpoint. And we really understand that this cannot happen for the next decade to come, right? So we have actually worked very much closely with regional manufacturers in the region of the Latin America itself to actually enable them, right, to create and to be able to manufacture more of the strategic supplies, be it APIs, vaccines, or some health technologies, right, like PPEs, to make sure that we, in the next pandemic to come, and again, it's not a if, it's a when, that we are ready and we are not going to be so reliant on certain parts of the world again. So with that, so now that we've done the demand shaping and the supply shaping, then that's the time when the whole economy of scale kicks in, right? Pulling all them all together into an international procurement process, helping countries to nationalize, as in import the goods properly, and at the same time, like we say, we actually work with countries to capacitate them, right, in terms of capacity building, especially around supply chain management, helping them to do planning, forecasting, and consolidation. All right, and all this to bring about accessibility, availability, and affordability. All right, so this is just a quick example that we have done just over the last 3 years, which is called the HEARTS Initiative, and that's essentially a regional program to help fight anti-hypertension within the region of Americas itself. So we applied pretty much the same concept, right? Rationalization of medicines. So we reduced from 50 molecules in the treatment protocol itself down to just 9. All right, and then we help to align the treatment protocols with the national EMLs of the countries, which right now there are 25 countries in the Latin American region that's already on this HEARTS initiative. And then with that consolidated demand, we establish long-term agreements, dramatically reduce the price, and you'll see later on. And then we roll it out and scale it up across the region itself. So this is a quick demonstration, right, of the effect of economy of scale. So we just picked two examples, right, of fixed dose combination of telmisartan and ablatopin. This is the strategic funds price that we managed to secure. And this is, so one key thing here, right, is this price applies to all the member states in the region, regardless of their socio-economic status. So whether you're high income, low income, or middle income country, you all have access to the same price, right? And just comparing that to the other price points that we've seen across the region, you could see the significant difference in potential cost savings, right? Some as much as a triple digit, 120% difference. Last piece is really just, to sum it all, right? In terms of what are some of the critical success factors for this to happen. I think what would really resonate, right? What our colleagues from Mexico actually mentioned. I think first and foremost, the most important element here is around political will and that the government has that so-called burning platform, right, to want to either eliminate or control a certain disease. Right. So without the political will, a lot of this will not be able to happen and facilitate. So I think that is the first and foremost, winning formula, right, or secret sauce. Second is really around standardization, alignment of treatment protocols. So I think we've seen that in the HEARTS initiative, right? So I think that's the second critical success factors. And the third one is around making sure it's sustainable. So I think continuous capacity strengthening and building, right, for countries is critical. As we have seen, many of the countries are really, and I think this has got to do with the other point that was, I think, brought up by an earlier speaker around the I think it was Dominican Republic, right? The constant change of government, all right? And this is a problem that I've seen happening especially in the Latin American region, whereby the health ministry itself, for some of the countries that we probably are aware, right, even within an administration of 4 years itself, it's changed like 6 times. So that really gives this whole unstable, workforce. Therefore, this capacity strengthening, it just becomes a continuous work that we all need to continuously do. And the last piece is really the market shaping that we saw earlier on, right? Shaping the demand, shaping the supply, and then they can then all come together. So this would be the 4 critical success factors that I would leave all of you with. And of course, I know I'm not doing credit to the Street Fund, but just running through. So I would really advise or advocate, right, that all of you go to the website and have a deeper look into some of the things that we do. And I'll pass the time back to you, JP and Kate. Thanks.
Thank you very much, Chris. This is really very, very interesting, and I like really the slide also on the criteria for success, which is really showing the complexity again and the need for quite a few actors playing together. You have been so I have one question for you for the organization. I would like the audience to be able to ask you a few questions. At the same time, I would like, I think we find of interest the next 4 short presentation in particular, because it shows success in areas of the world where you were before. I know you were from Singapore before. You worked a lot in Asia. So would you have the time to stay with us for the next 4 presentation and take a few questions?
Sure. I'll try to stay as much as possible. But yeah, I would love to actually, but I will try. But if I have to leave midway, I will let you know. And of course, I think we can still take the question offline if possible, if that works for you.
Let me maybe have the first next speaker, because I know that he has a commitment and would like to first talk, and there is a small change in the program, and Dr. Pulungan from Indonesia has asked to speak first. So if we could have Ahmad's presentation, that would be great. So he's going to switch. Okay, because I don't have his presentation, but he's going to switch it. Okay, so that's fine.
Hi, JP.
Hi, Ahmad. How are you doing over there?
Okay, yeah. Yeah, I just got back from India.
Oh, okay.
Okay. So, can I start?
Please.
Yeah. Can you hear me quite good?
Yes.
Okay. Okay. Hello, everybody. Yeah, good evening here from Jakarta, Indonesia. I would like to share about the understanding challenge of celebrating success globally, challenge and opportunity around access to fluorocortisone and hydrocortisone, and what our experience here in Indonesia. So the background is the global story of access to fluorocortisone and hydrocortisone, and CAH in Indonesia, and also history of fluorocortisone and hydrocortisone in Indonesia, and conclusion, the challenge of the opportunity. So we know about this, the high mortality, and also live untreated, about about 75%, but salt wasting. I think we already know about this. And the global story to access fluorocortisone, early 2000, Indonesia, Vietnam, and Philippines, Pakistan, we face a universal challenge to access essential medicine for CAH. And since 2008, there are multi-sectoral effort have been made to drive the access, initially supported by humanitarian donation from a clan. All 4 countries have since improvement in access to essential medicine, Indonesia and Pakistan. And finally, we got a local production availability of low-cost medicine, hydrocortisone tablet. And Vietnam also, national registration and important from affordable quality support. So this is the global story access fluorocortisone, and we can see here from the yes and no column what happened in Qatar, Egypt, Pakistan, and also about hydrocortisone. The upper quadrant is about fluorocortisone, and you can see the lower one what's happening in what hydrocortisone in some country. Yeah. So CAH in Indonesia, what I would like to share, the thing is quite difficult to get the real data. So what we have right now is registry collaboration also with the community of CAH. So the national registry rapid increase over 14 years. So about 600% increase in total patient register. Yeah, I'm saying about the register, so the registry. So when we start the community, a lot of patients, of course, register right now, and most of the patients register from the Pet Endo Society. No screening right now, and many cases remain undiagnosed. So next Monday, I think we're going to talk about screening. So increased risk of mortality, of course, due to underdiagnosis, especially during this pandemic. Yeah? So the hydrocortisone and fluorocortisone in Indonesia, before 2006, neither medication was registered for sale in Indonesia. So access was variable at best, always expensive mostly. So following a request for support, a clan first sent emergency humanitarian supply hydrocortisone and fluorocortisone tablet to CAH patient in Surabaya in Indonesia. So we start collaboration with clan, with Kahaki also, and even when we had the UN meeting in Melbourne, I was taken a lot of tablets from Kate, from clan, hand carry to Indonesia during that time. And 2008 to 2011, for 3 years, we had the donation, and some of them also we have it, also from US that time. And we have the CH community. So members of patient, caregiver communicate through WhatsApp right now, sharing practical tips, including access to CH medicine. And also from this community, we can start a lot of research data from this community. So a decade of hydrocortisone history of Indonesia. 2008, Indonesian Pet Endo Society began working closely with Indopharma, the local pharmaceutical company, to produce the biggest government company, local hydrocortisone. The challenge during the time, significant was needed to navigate, and bureaucracy issue. So I think it's happened everywhere. There is also bureaucracy. And source of medication in the interim, we got it from Netherlands, Singapore, and Australia, and yeah, mostly from Netherlands to center of Java, yeah. And 2018, hydrocortisone genison was made available in the market. So thank God, 2018 we can have it in our own. Hydrocortisone by injection, we also have it right now from our local company. So we call it Fartison. And fluorocortisone. So 6 years in process from preclinical to the patient. You can see it 2017, 2018, preclinical. So there is a company. Before 2017, we have collaboration with one company also in India, and we have start collaboration. There are 3 companies in local trying to make it, and finally they don't have interest, and even Pfizer, they don't have any interest. So 2017 and 2018, there's a local small company, Sidna Pharma. So they try to clinical document preparation, Sidna Corp, the name, a new drug, no similar product in Indonesia. So 2018 to 19, first formula developed. And 2019, 2020, second formula adjusted. And they start for pre-registration approval by our FDA, BPOM, 2020. So the study bioequivalence start from 2021. Registration started 15 May 2021. So we hope, yeah, we pray, estimation the product will be launched in May 2023, the fluorocortisone local product. So what's the price, the cost in Indonesia? The Genison, our local product, is covered right now by National Health Insurance. So, but available also across the region and partly out of pocket. Sometimes they have to buy it, but sometimes they don't prepare it in the local government hospital. That's the problem. Even though the government said they have supported. And the hydrocortisone, approximately 11% of Indonesian average monthly income. So they about 175 US dollar per month the patient have to pay. So the hydrocortisone about IDR 12,500 per tablet. So it's about per month about 20 US dollar. Fluorocortisone currently we still have hand carried from overseas, from Singapore. From the Kahaki, they send someone to Singapore and they bring it to Indonesia. So still out of pocket. And near future, locally produced fluorocortisone will be less costly. The Sidnacort, the fluorocortisone 0.1 mg would be 6,000 IDR per tablet. So approximately average around 11.75 US dollar per month individually per patient. Yeah. So we will. I just talked before this to our Minister of Health, and I think they will help also register this in our government insurance if it will be produced in Indonesia. So the conclusion is still a challenge. Supply side factor, internal barrier, bureaucracy, everywhere issues lead to extended time production, single local manufacturer, lack of competition, relatively high cost. Yeah, and also demand side factor, financial, affordability, partial out of pocket due to varying availability of hydrocortisone. Fluorocortisone remain out of pocket. Many cases remain under diagnosis. Opportunity. Of course, external support of donation beneficial for the short term, but not sustainable. Locally produced fluorocortisone will reduce cost. However, maintain access to essential CAH medication is the key right now. Urgently, fluorocortisone cover under National Health Insurance Scheme. I hope we can do it, yeah, when it's available, and we can talk to our Minister of Health. So the proactive CAH community, thank you to them, because the community members actively communicate to inform access to CAH medication to each other. Thank you. Over to you, JP.
Thank you so much, Ahmad. That was very nice and enlightening presentation. What you have highlighted actually is the importance of a community of families. So that's one thing. And the other thing is that you have also highlighted, when you are a large country, I don't know what the population is in Indonesia, but it must be 200 million, something like that.
Yeah, we have population 270 million. Our children population 90 million. Our newborn 5 million every single year.
So it's a very, very large country, and you have taken
an
approach which is taking the problem into your own hands.
The Minister of Health want to try, because I had a lot of discussion with them. So because we start the launch for the CH screening, so I already told them, why don't we start at the same time also CH screening? Because our data, about 1 in 1100, I think, for CAH. So it's quite high compared to any other country.
Yes, this would be a very, very high incidence. I guess there is more consanguinity for recessive disease in Indonesia, which may be part of the explanation. But so
yeah, probably.
I think that you have highlighted a lot of potential for the future also. Maybe what I will ask is that if anybody has a question for you, because I know you are going to disappear soon from the audience. The price you are discussing is, of course, much more affordable. I assume it's still a pretty high price for an Indonesian family. I mean, $11 per month is not negligible, but at least the sustainability has been vastly improved, actually. The system that you have
it's quite affordable, but I think we have to ask the government to support this. This is for a lifetime. And also for years, they will use it, for quite a long time.
Absolutely. Yeah. So I think that maybe I will let you go, Ahmad, and I think that the next presentation, if you still have a few minutes, and you know it very, very well, is another success story, which is by Dr. Raza from Pakistan. Well, to some extent, they have also taken, if my understanding, the matter in their own hands in order to produce locally the fluorocortisone with success. One last question for you, Ahmad. Do you think that your system is exportable? So do you think that Indonesia would export? Is it a private company that is eager to export the tablets, or is it something which is really for the Indonesian population?
I think, I don't know, I cannot hear really good, but the thing, I think...
do you think that Indonesia would sell the tablets to other countries, or would this be for the internal market?
I can talk to the company, because they will produce at the beginning, I think, 100,000 tablets.
Per day, per month?
100,000 tablets per year.
Per year, okay.
Yeah, so this is quite a lot compared to our data right now. So I've been talking to them. I don't know, maybe if, we are not going to use it for this first year, I think, I can ask them to send it to another country.
just for information at this point, but I mean, I think this is a nice progress that we have been pushing for in Indonesia.
Yeah.
So maybe I will let you go and I will ask Jamal to step in.
Okay, so see you on Sunday, yeah?
See you,
Yeah,
Aman.
thanks, Aman. Aman is speaking at a UN event that we have on the 6th on newborn screening. So thank you, Aman.
Thank you. Am I audible here? Can you hear me?
We can hear you, Jamal, yes.
Yes.
Thank you. If I'm allowed to share the slides, I'll try and do that. Otherwise, I'll just
You should
speak
be able to do
otherwise.
so.
Right, let me check. Yep, okay. Can you see the slide?
Yes.
Thank you.
Okay, I'm not sure how do I turn the slideshow. Yeah, that's the one. Okay, I'll be brief with my presentation because we have limited time, but I think it's very important to share with you the success story for others to follow. We have had problems with the availability and the accessibility of medicine, as in many countries that I've just heard from South America and possibly across the world. We first look into the situation whether the medicine is listed on the essential medicine list, and we found out that yes, it is listed on the essential medicine list. We'll talk about the COVID challenge in a minute, but let's first talk about the availability of the medicine. So it was included in the essential list, but nobody was ready to make that medicine, and so the medicine was not available locally, and it has to be, as mentioned, smuggled or procured from outside, and the prices were astronomical, as well as the availability was always questionable, which was a huge problem because once the medicine is not available for these children, and not just for CAH but other conditions that require hydrocortisone, it's really a matter of life and death, genuinely speaking. So we tried for many years by luring the international pharmaceuticals like Pfizer and other to make this available for Pakistan, but somehow it didn't work. So finally, we resorted to other own avenues, and with the help of Almighty Allah, and we have been able to manufacture. We have been, because one of the reason the local manufacturers were not very interested in preparing the medicine because it's a very low cost medicine. Sorry. So it was not very profitable for them, and the numbers were not that high. So it was not very profitable for the industries to make these medicines. But we finally got somebody interested, and we told them that it's more to do with saving human lives rather than earning profits in this situation. And we got somebody convinced, and we started making the medicine hydrocortisone under the name of corticote and fludrocortisone under the name of fluorocort. And if you look at the prices, it's amazing because the prices, as I said, was astronomical previously, and it was even $1 per tablet. But once we got this made locally, now with the dollar fluctuation, the cost of the local medicine available to us is less than $0.50 for 30 tablets of hydrocortisone and less than $0.50 for 20 tablets of fludrocortisone. So that's something like 1 cent per tablet. That's dirt cheap. I mean, that's really amazing that we have been able to procure this medicine now. The availability is also now consistent, and the price is so affordable that it is affordable for everybody. Then we hit another problem because when the COVID came, we were thinking of doing another project like distributing the medicine at the doorstep of the patients, because some of the patients are coming from very far away. And when at the public sector hospital, even when we were giving them tablet free of cost, it would cost them a lot of money to come to the hospital. Sometimes the whole family comes over, and then it was costing them a lot. So we we thought that, instead of them coming over, why don't we deliver the medicine to them through a courier service? And we figured that out, and we did that for about 50 patients initially, which were living very far away from the facility that we were operating. And it just costed at about $1 to $3 per shipment. And then the COVID hit. And, that was very fortunate because there was no way during the lockdown for the families to come over and get the medicine. So they were extremely, extremely thankful that they were getting the medicine at their doorstep. And you can see the families were coming, some of the families from very far away from where we are operating in Karachi. So then something else also happened, that because of this low price, we were not just able to provide the medication now for our own patients, but also have extended beyond borders. And the first shipment that we made with the help of the clan who supported the cost of the medicine was Zimbabwe. And, when the patients were not getting the medicine, we were able to ship the medicine and provide this for the children of Zimbabwe. And very recently, this month, we have also been able to deliver some of the medicines to Sri Lanka and Colombo. So this is one of the success story that I wanted to share with you. And I think we have just had a presentation from PAHO, and I was listening to that. And that would be a wonderful opportunity if an organization such as PAHO, I don't know whether our guest speaker is still here with us, but if they are here, with the cost as low as 1 cent or even less per tablet, and the quantity is not that large, the one of the organization can procure a bulk of these medicine for something like South America, and then maybe get through the local or international tenders and make this tablet available for children to be of use. And it is certainly something that is actually life-saving. Just a couple of comments before I stop. Screening is not available in Pakistan and is going to be very expensive. So for some of the countries where I think screening is still not available, and increase awareness to the medical community, to the doctors, looking after these children with problems like adrenal crisis, can help tide over the deaths that are happening because of the late diagnosis, especially in terms of the male children, because females can sometimes come up with ambiguous genitalia, which in a way makes the diagnosis a little bit easier. But for the males, it is sometimes difficult. But increase awareness till such time that the screening is available can be one of the solution. One thing that, Kate, I would request you to include in your plan when you were talking about 2030 reduction or improvement in the management is the cost of the investigation. Because over here in Pakistan, at least that I know, and I'm sure many of the other countries would be having same problem. The investigation is very expensive, and it's not just investigation for the early diagnosis, but also for the subsequent management when they come in for the follow-up. You need to regularly have the test available for the medicine to be monitored and altered. So I think as far as we are talking about the cost and the availability of the medicine, we should also look into the possibility of doing something to make the investigation more approachable and more affordable for the population for the better management of children with CAH. Thank you. I would stop here, but I would be very happy to answer any questions if there are.
Thank you very much, Jamal. This is really a nice success stories and is built also on the presentation from Aman. I think that what I see here is well, again, the lack of interest from international pharma that pushed you to have your own system. The second thing is that I'm quite admirative of all the physicians who are presenting today, because these are way more than pediatric endocrinology seeing patients. These are really colleagues who are going outside of the usual in order to get product for their families and children. So that's really quite amazing work and very that goes way beyond just clinical science. What you also show is how low you can go with the price. I mean, the price in Pakistan is very low, and maybe you can comment on that. I just had a colleague leaving the room because he's going to another meeting in Chile, and he's from Chile. So this is also relevant to Dr. Lim's understanding of South America. And Chile does have sustainability of the drug, so it's there. Fludrocortisone is available at the price of $1.2 per tablet. So I mean, Chile is it's a richer country, but still, it shows that we go from a few cents to many cents for one tablet. So maybe if I know, because you are working remotely, maybe there is a way to ask, anybody wants to ask a question to Jamal?
Hi, this is Michel Polak from Paris. I'm speaking because I've several points of contact with what you say. First, I'm responsible also for a newborn screening program. 180,000 people per year.
Sorry, can you be nearer the mic? I could not hear you very clearly.
Yeah. Okay, so Michel Polak from Paris, so I will make it short. My question is the link with industry. Because of course Pfizer is not interested. They want to make at least 200,000 million euro per year or dollars, even for rare disorder. No, seriously, I discussed with them at a high level. The point is, I think middle level industry can be interested, the one that do not. So my question is, what is the sustainability for the industrial that you choose for your own product in your country?
I mean, this pharmaceutical is not just producing this medicine. It's a established pharmaceutical company which is producing so many other medications. So this medication is only one of their products. So I don't think sustainability will be a problem. Maybe with the dollar fluctuation, with the global inflation, the cost may go from 1 cent to 2 or 3 cents. But that's about it. It's not going to go any further than that.
No, that I understand, but my question is also, did you look into their business model? I think it's very important for us academic pedando also, to understand the business model that they are providing. Because are they making a little money? Are they making no money? Or are they producing it because they have a lot of production outside, and they want the image and the environment that gives them through a production of potential life-saving drug? Do you know the business model that they are developing?
I think right now they are producing this. I mean, not expecting to make huge profits from the product, and they are doing more as a part of the service to the community. But I'm sure they would not be doing it at a loss. They would still be making some profit, if not huge. So I don't think that sustainability but we can look into it into more detail. If we talk about bigger numbers and supply across the globe or many other countries, then of course the business model has to be relooked at.
Thank you very much, and thank you for your huge action. Very successful. Congratulations.
Thank you. Thank you very much.
Thank you, Jamal. I saw that Dr. Lim was planning to leave. I don't know. He had a question for both you and Jamal. I don't know Aman, I don't know whether Dr. Lim is still around or not, or if he has already left.
I think he's left, JP. I can't see him on here.
So this raising the hand was about contacting Jamal and Aman in order to understand better the model that you have and how. So I think there was interest from his part, and I will make sure that we can put you in contact with Dr. Lim after the meeting.
He has
most certainly.
He put his email into the chat, so you should be able to find Dr. Lim's email in the chat. Can I just make one other comment about your question? And I think it's a good question about the business model. And CLAN never requests any cheap prices on drugs. We ask for the business price. So we make it very clear to the pharmaceutical company that we're working with that so Plan does not accept any money from pharma. We don't accept any donations from pharma. And we say to the pharma, we're not asking for altruistic donations. We want to know the business price and we'll pay the business price because we have to find sustainable solutions.
Thank you.
Can I make another comment? Sorry. I think the comment is on newborn screening. In our system, so this is not, the second tier is not mass spectroscopy, that will be the system, but we have a predictive positive value of only 16%, 16%. Let me remind you that for congenital hypothyroidism, the best screening program, the predictive value is around 75, 80. So my question is, that should not be taken into account alone. Such a screening program should screen for many disorders at the same time, or at least few disorders at the same time. You will not be, I mean, in my mind, you will not be able to put the newborn screening program only for CAH. That will not work with the health authority. You need to bring congenital hypo at least in the bag.
No, we have the congenital hypo started in Pakistan, and we are currently doing it. But we need to add the model for CAH once we have the numbers and once we have the money to add on to the other disorders.
I can tell you the cost, for example, for us, 185,000 filter paper a year at Necker University Hospital in Paris region. 15 euro per child for 13 disorders, 13. So when you add up the disorders, then the cost per disorder will decrease.
I understand, but the population is so huge and the number of births is so high that the cost becomes very astronomical, and it's not easy for the health authorities to take that.
Yeah, I understand. Thanks.
I just wanted to put a short comment before giving the floor to Rodolfo. You mentioned something important, which is the diagnostic test that, and the screening and follow-up tests that are expensive. And
yes.
Just to let you know is that besides the EML, the essential medicine list, the WHO has initiated an EDL, the essential diagnostic list, and I happen to be on this committee. So 17-OHP is going to be likely on the list soon, which doesn't solve all the problems for sure. It's one step in for the medicine is getting on the list. But the WHO is also interested in supporting the member states or the countries in organizing the setup for diagnostic test, which is a very important part, of course, of CAH.
Yes, that's very nice to hear, and I think that is how we should be moving forward in terms of solving the problems of management to also bring down the price for the diagnostic testing.
So the WHO is looking for countries who are interested in starting a national diagnostic list similar to the national medicine list.
Excellent. I would be in touch with you and see what we can do from Pakistan.
Okay. Thank you, Jamal. Rodolfo.
Thank you very much.
Thank you, Jean-Pierre. Rodolfo Rey, Buenos Aires, Argentina. I'm sorry that Dr. Lim is no longer there, but I just want to raise this concern. Because Dr. Lim talked about quality, and that's very important. No, it's very important about quality. We usually do not talk about quality. The issue is, it seems that quality and feasibility are a little bit one against the other. I mean, quality, some countries, and we have the history, the story here in Latin America about the GMP requirements of a not very high income country, but GMP requirements by the state that made it almost impossible for any small company to meet them. And then we know in our countries there are capitalist interests that make that the requirements are like if we were in, I don't know, in Denmark or and so how to work in this sense. Of course, quality, resilience, quality is not the choice, but how can we work on this and make small companies be able to register their products in these countries?
Yeah, Rodolfo, let me answer to you, because I develop drugs and pediatrics as well, and I know very well the ICH requirement to develop drugs. I think our duty is also not to deal about the quality for the children we are taking care of. I understand your point, but at the same time, quality drugs are really required. And when people do like suspension in their area, homemade, kitchen made, I mean, they do not match the stability, they do not match the assays for bacteria development. And so there is a risk there, and this is really worse than not developing according to at least minimal ICH, international quality requirement. That's the first point. The second point is I think that we didn't talk at all about what is called name patient use, but we targeted a little bit by saying, for example, what about the exportation from Pakistan? What about the exportation from Indonesia? Name patient use are programmed. If you require the drug, you may import it. So you may have the quality that is given to Pakistanis children, and you may import it to Argentina, and that may, in a way, because it's not expensive, that may help.
Let me, can we, because we have that last thing after that, because we have two more presentations and there will be time for but maybe you want to answer the questions for. We have tried also. I mean, it's not a problem in Argentina, it's a problem in the region. We go on talking and privately, but we have tried all what you said, and as I said, quality, resilience of quality is not a choice. You cannot cut quality. Quality must be there. The problem is governance.
Okay, thank you. I will just answer your comment because before I forget on the issue of registration that are difficult in various countries. An example is the WHO does also have a system of WHO registration. And if countries say, okay, well, I accept the level of registration that WHO is preparing, then I don't think the company doesn't have to do the same in their own country. They just did this for insulin, actually. So there is a approval of several insulin, including analogs with the GBED as well as NCD-CHA push for that, and it has been done a few months ago. That says that, okay, if a country says, you know what, it's good for me to have the seal of the WHO, if the company meets this criteria, we just take it in our country. So it makes it easier for companies. It has not been very successful with diabetes. So insulin companies have not come to the WHO, to the country saying, you know what, I registered to the WHO, please accept me, it will make it easy. But that's one of the potential pathways. No, we have, Jamal, you have just talked, so the logical next presentation is certainly from Zimbabwe, because the program you have worked on has been really exported to Zimbabwe, and it's a very interesting presentation.
Yes, I would be very happy to hear that. Yes, thank you.
So, okay, yeah.
Dr. Priska, would you like to share your presentation, please?
We can't hear you. So this is Dr. Prista from Zimbabwe. We just are fixing the sounds. Just 2 seconds. But you are muted. You are muted. You may want to unmute yourself. There we are.
Hi, can you hear me now?
Yes.
Greetings from Zimbabwe. Let me start my screen sharing. I'm just going to remove my video for a little bit so that I can have a good bandwidth. Please confirm you can see my slides.
Yes, we can see your slides. Perfect.
Awesome. So thank you so much for having me. My name is Dr. Priska. I work in Zimbabwe, a country in sub-Saharan Africa, and it's been great to hear the presentations from the previous speakers. It's been awesome, and well done to the previous speakers. And it's been good to also meet Jamal. I think this is a very good a platform to really share what's happening across the different countries. And it's been awesome to see some of the people who have been behind our success stories. So our country is in sub-Saharan Africa. We are a small country. We've got about 16 million people. And our health system really stems from the primary health clinics, the very small clinics. And then a patient is referred from the primary clinic to the rural health center, district hospitals, up to the provincial hospital, which is a much bigger area. And then finally, our highest level is a central hospital. So I'm working at one of the central hospitals in the capital city in Harare. And it's one of 5 central hospitals in Zimbabwe. And most of our pediatricians are really located in the provincial and central hospitals. Some subspecialists are now in the central hospitals. We've had quite a number of subspecialists over the past years. We've got about 60 pediatricians in our country, and we all belong to an association called the Pediatric Association of Zimbabwe, and we are all talking to each other. For most of us, life has been about being a general pediatrician. And then for me, I've had to do endocrinology, and I do appreciate the amount of work that is there, not just for me, but for the other pediatricians across the country. So there's a lot of collaboration that we have to do when it comes to looking after children, because it's not possible for one endocrinologist to look after, all the children in Zimbabwe. So all of us are almost doing a lot of things at the same time. So our story with CAH is really a before and after 2018. Before 2018, not a lot of dedication was there for endocrine conditions. A lot of the pediatric NCDs were not fully recognized. Our country was going through HIV, malnutrition, TB, and a lot of other things. So a lot of the focus was on those conditions. So you'd find that patients with endocrine or CAH were really, sent from one place to the other. There was no one who was dedicated to look after those patients, and investigations were largely unavailable at that time. And then from 2018, when we started looking at, when we started a clinic for endocrinology, we did have a lot of work. Most of it was to tell people about the endocrine clinic, making sure that patients are referred. And sometimes it would be so difficult for patients to come from across the country to come to the capital city. So we needed to do a lot of work in terms of also teaching health workers in terms of how to identify CAH, what to do about it, and some of the things. So there's been a lot of work in terms of that. And most of our training is really to the pediatricians, to the nurses that are pediatric trained nurses, and also to GPs that are working outside the country. And over time, I'm happy to say that we've had a lot of like-minded partners, and some of these partners were, groups like our CYC, our Child Youth Care, an NGO that is looking at rare diseases. It had to partner with CLAN. It had to partner with a lot of departments in the Ministry of Health in the head office. It had to partner with a lot of people who are looking at essential drug lists and all sorts of things. So there's been a lot of work that has started, not yet completed, but there's been a lot of work when it comes to that. And we're happy to say that the patient voices have grown louder. There's now more awareness and referral to our clinic. So our endocrine clinic is looking at CAH, is looking at DSDs, is looking at, diabetes and any other endocrine diseases. And we are happy to say we've started recording some of the cases that we are seeing over the years. So with CAH, again, like I said, it's competing with many other health challenges in our country. We don't have a newborn screening available, and this is something that's not in the immediate horizon. We also face diagnostic challenges. Some of these tests, like the 17-hydroxyprogesterone that we're talking about, is not available in the public health system. So patients have to fork out money to send to a private lab. And right now it's costing close to $100 for that test. The genetic test karyotyping is not available again in the public laboratories, and patients pay close to $200 to $300 for something like that. So it's been very difficult trying to get some of these things done. We've been trying to lobby for them, but most of the public health laboratories do not have that capacity yet. And treatment, again, was an out-of-pocket expense. Patients, families would be forking out close to $30 to $50 per month. And the monitoring tests were not feasible. They're still not feasible. And most of our assessment is really growth assessment, trying to see if the child is growing, is doing very well. And we've also had challenges when it comes to surgical skills and theater time. Most of our patients are girls, really need some sort of surgery, clitoroplasty, when they are 5, 6. That's the time that they usually schedule them for. So we used to have one pediatric surgical specialty who would do the endocrine issues, but he's left the country. So we've had to go back to the drawing board and ask some of the colleagues to be trained outside the country. So they've had stints outside for a couple of weeks, and then they come back and they do something like a block release. So we do now have some sort of surgical skill, subspecialized surgical skill for these children, but they are competing with other things. Our pediatric surgical department is housed at the hospital that I work with, and they've got a lot of other cases that they're looking at, acute cases. So you'd find that, a patient who needs surgical expertise will need to wait, and they are postponed until 2 years later, they are still waiting in the list. So it's been quite a challenge for some of our patients, and they are really trying, but that is a big problem. We also had suboptimal psychosocial support. We didn't have a support group for these patients and their families, and they needed to have someone to talk to, someone to help them across the journey, because having CAH means that you are going to need support for a long time. So we've had to address that as well. And we are happy with the success so far. We are so happy that we've got motivated parents. We are happy that we've got parents who are now advocating and crying for things for themselves. We are happy with the links that I've talked about. And this has brought very important things. It has brought hydrocortisone and fludrocortisone. So we've had a supply of 3 years, and this has brought relief to most of our patients. They talk about how it was so difficult. They didn't see a future before this donation, and now they are happy. They know that at least we've got somewhere, to start with. And then we've also had strong support from our hospital admin and pharmacy. They've been the ones who have pushed for fludrocortisone, for hydrocortisone to come to the country, and they've done the necessary paperwork, because it has to go through the ministry, it has to go through the pharmacy department, it has to go through Medicines Control Authority, and all this paperwork is not possible if it's just you and you clinician and looking for a donation. So we've had lots of support from the admin, and I'm so happy that the same admin is really helping when it comes to diabetes. We've had linkages with other organizations like Life for a Child, and that support is really important because it makes a big difference on patients' access. It also helps in terms of monitoring, making sure that the drug stocks are monitored. They're actually collecting data as we go along. So I think that's been a success on our side. And we've had to, like I said, address the psychosocial aspects. And we've started working with child youth care, and we've started a support group for children with CAH. We don't have a lot of children right now. We've lost some of the children along the way. We've lost numbers and phone numbers and people. We've lost patients because they are coming from all over. But we've got a cohort right now of about 10 children, and we are hoping that we can have more of them. We've had to do a lot of multidisciplinary team meetings. We've had surgeons, we've had pediatricians, we've had psychologists, we've had nurses, and we really want to increase the number of those children that we pick up. I'm sure we've all been talking about how it's very difficult to pick up some of these children with CAH in the newborn period. And we know that we are missing a lot of them, particularly the boy child. So we really want to make sure that, you know, our nurses out there are picking up sick children and are able to refer them very fast, you know, and they are picking up ambiguous genitalia and referring them. And even the older kids, we want them to be picked up quite early. And that's a lot of work that we're doing. And all that advocacy, we've been doing that for the past 2 or 3 years. So I'm sure you've seen that photo before that Kate flighted. This was our very first support group meeting with our patients with CAH. And we are hoping that we are going to have more support groups for rare diseases. We are going to include DSD. We are going to include other rare diseases in the same kind of format. And I'm so happy that, you know, with all those people coming on board, I'm sure our future is a bit brighter than what it was before. I think I'll end here. Thank you very much.
Thank you very much, Dr. Priska. It looks like you are in the room. The connection is one of the best I've had with Africa. So
that's awesome.
So when I'm looking at the schedule, I'm trying to see that hopefully will you be with us for a little bit longer?
Yes, I think I'll be around for about an hour.
Okay, so why don't I ask our last speaker, Dr. Salwa Moussa, to present for Sudan, and after that, we are lucky, we will just have a little bit of food we can put on the table. It will be a 5-minute interruption, and then we can really start answering any questions and discussing. So I would like to invite Salwa from Khartoum, Sudan, to present what the situation is in her country.
So glad to be here today. Sudan is a very big country in slightly northeast Africa, and it has the central Sudan, which is the main city in Sudan, which is around 45 million. We have a very high rate of consensus, but it is from 44 to 63. Very high rate of consensus. Then Sudan has a very big group of ethnicity. So we have a lot of ethnic groups. That's why we have many diseases, different genetic backgrounds. The outlines would be background about situation in Sudan, and then various for early detection of cases of CAH, challenges in diagnosis and management, and then opportunities and efforts for finding cases with CAH. Sudan is a very big country, and we know around 45 million, and have very high rate of mortality, reaching 63%. Have very large group, very large community group, so it has a very big diversity of genetic conditions. So the story begins, I think, here, where we published this paper regarding the etiology of primary insufficiency in this children. And we found that we have more than 400 cases of primary insufficiency, and more than 80% are CH. So we have a very big group, and we have many challenges in diagnosis and management, and this is just considered the tip of the iceberg, as many cases remain undiagnosed. Those are just the cases that we found in our this is another paper regarding etiology and clinical method of health studies. Also, we found that we have many cases of deficiencies with cortisol as well. What is the various for early recognition of these cases? We have known even the same program, not for CH, not for hypothyroidism as well. And males are easily get diagnosed because, as you all know, that the children probably the male are not. But the situation is not better in females because also in Sudan we have cultural stigma. So patients tend to hide female patients with they reach very big. And we have a lot of home deliveries in Sudan, especially in the peripheries. So recognition is probably. And we have unawareness among healthcare professionals, midwives regarding CH. Sometimes we have missed gender examination by professionals, and we have unspecific presentation, especially male, where we can where the presentation can mimic many conditions like gastritis, ARI, which is very common in our population, and have no proper referral system. And then we have very limited diagnostic facilities and the cost. We don't have 70 hydroxyurea stored in Sudan, so we have to send it outside at very high price. Fortunately, we have good methods for this specialized in the pelvic ultrasound. And this we can send the patients outside. So the barriers for early medical difficult access to medical service and and again, barriers regarding the management. Sometimes they saw that those kids are sexual or undefined online or eyes and social media. And patients are running government hospitals, so there's very limited access to diagnostic. The adherence of medication is also one of the problems with those patients. Usually they live in very remote areas that access harmful then there is no health insurance for more than 50% of patients. And the cost of the surgery is very expert surgery with more than I participate in this access to the cortisol and oral and cortisol. Unfortunately, there are research but the oral and cortisol is available for the first time and it's very small in national drug supply from but the oral cortisol was included in the 2013 but was for no reason in the 2019 and that is not despite many specialists and tablets of cortisone are there from various manufacturers the price but it's only available less than 5%. Patients get the medicines at higher price in private pharmacies where they have to struggle with drugs, right? And then availability of a lower in this case. So we have
supply. And in the absence of cortisone, sometimes we add more salt to the diet and we increase the cortisone by 5% to increase the okay. And in the absence of cortisone, we use options for patients. So what are the opportunities I'm going have three pediatric private clinics specialized in we have separate and now we are launching separate so and we have many efforts to increase the awareness and education. We have alert transportation CH. We have very good participation and we have just had a meeting last week to start education support parents and we have searched for international collaboration. But now some collaborations but it's on commercial basis, but we convinced the health system to pay 50% cost of the patient. They have to pay half of the price. And we have to raise with different parties. We had meeting last week with Minister of Health, convince them so as to access the application is on, and they said they need numbers. So when we have registry, we had very successful stories. So I think
Thank you very much, Sarah, for this nice presentation. And again, it illustrates how a number of actions we are taking beyond the clinical care of a patient in order to try to get the medicines and test in the patients. Emphasize also the collaboration, and I think that's something we can emphasize. So maybe what I will do is then ask for John to come, and it will be 5 minutes so that we can maybe meet at the table once it's there. Meanwhile, I don't know whether there's any questions for Dr. Priska or for Dr. Salwa. But in the meanwhile, I'm going to do the dishes in the kitchen and coming back.
Food cortisol removed. Here in Argentina, we had the whole Ministry of Health removed. Did not have Ministry of Health between 2017 and 2019. Ministry of Health.
I do think that one of the things I answered one of the things that Kim and Jamie and I were talking about, just like you were saying about obtaining numbers, that trying to build registries, that trying to figure out numbers in different countries in order to be able to better is really important. Hoping that we can also share how that's particularly the places without newborn screening. I think that the other argument for newborn screening is, well, what are you going to find to the point of ascertain the value of screening? It's hard to build a newborn screening program unless you feel like you're actually patients, and it's also hard to build a newborn screening program access to medication. So my concern is that we get into this cycle of we don't have the numbers because we're not treating them. But we're never going to get the numbers unless we decide to start treating them. So if people have thoughts about how they develop those registries, who's actually doing that work, very interested to hear. Jamal and Amon left, but actually Joseph, are you still on the line there? In Vietnam? It's as simple as yeah, just making a start. We're not seeing the children this age, they're dead. So apart from what you see is but I think that Dr. Priska might want to comment. But I think that yes, she's the only pediatric in Zimbabwe, but all the other pediatricians know that she specialises in pediatric endocrinology. You don't really need to email everybody to find out. Did you want to comment on how you're setting up a register in Zimbabwe, Dr. Priska? I think she may be having a little trouble hearing. Dr. Priska, the question to you was if you wanted to comment on the registry that was set up, that you have set up.
Okay. I could hear that. So yeah, we are trying to set up a registry. We managed to get a phone that we can use with the red cape. So we are trying to link that because we were using that particularly for diabetes. So we are trying to link that the registry so that we can put the other rare diseases that we are working with. So we were going to be working on that very soon.
One thing that you have said, Dr. Priska, and that Dr. Salva also have said, which is in the absence of screening, to make sure that the children actually get a genital examination at birth. Whereas in many countries, it's just not happening because the babies are born and the physical and genital examination are not part of routine practice. It's certainly not as good as the screening, of course, in particular for baby boys, but it's certainly something that can be improved in many countries also, like you have been mentioning, Dr. Priska and Sam.
Okay, I think I got something about genital examination. Is that a question directed to me?
Yes, well, it was a comment directed to what you said. You mentioned
Right.
you had emphasized the importance of genital examination in babies, and I think it's important in the absence of the screening.
Okay. Yes, well, we do have a lot of the nurses looking at it. We've tried to also highlight that, but in our population, we are very happy because some of the grandmothers are the ones that do the genital examination for us. So we've actually had referrals from grandmothers because they've said something is abnormal with this baby. So we've had success on that part. The grandmothers are sure to check.
Yeah, Michel Polak from I don't know if my comment will help, but for registry of Salamet within the ONDO ERN, European Reference Network, which gathers a lot of factors in the field in Europe, and set up a registry for that has expanded it beyond Europe. So, I mean, there is a way not to reinvent the wheel.
Yeah.
Okay, thank you. I think you said something about the registry, that there are already some registries that are available, isn't that?
Yes.
Okay, all right. Yeah, we have looked at some of them. The issue has been about some of the registries are quite cumbersome. There's a lot of information that's needed, and some of the things are not really something that we are doing on a routine basis. But we are looking at it as well. I think we need sort of something that is a bit less cumbersome, something that doesn't take a lot of Wi-Fi or internet on our part, because that's a big problem as well. That's why I was talking about the cell phone. We actually do an offline recording of information, and then we upload it when we get some Wi-Fi. So we are trying to marry some of the things that we are collecting with the Ministry of Health database. So we are trying to work with them also so that we could have a standardized way of collecting data, because we do collect data even from the peripheries. So we try and make it something a little less cumbersome for that aspect. But when they come to our clinics, we definitely need something that's a bit more than what everyone else is collecting. So thank you. I think we'll also consider that as well and see what works for us.
remind you, I was the chairman of the committee. So there are research projects. I was the chairman of the research project. And each year, IFCA gives away to researchers 350,000 euros. So I'm not saying that IFCA will help in those matters directly, but I'm saying that if you want at some point to evaluate the efficacy research setting, then you may come with a project to the IFCA committee. Letter of intent issue there is. So IFCA may help in terms of evaluation of some action that you are. That's coming from
I'd just like to respond. CLAN has unsuccessfully has GPED, and we have a current application in the PIFCO.
The standards are very high and the committee is very selective. We know that, but keep trying. And use the help of methodologists. Magic word is research. That's the same.
To Margaret Secretary to Australia. The registries are very important. The award screening is very important. So we have an ascertainment of incidents, but there remains this enormous gulf, which is different between many countries and religions and cultural issues as to whether the patients can access the medications, understand the needs of their children, and will be able to, for many reasons, comply with recent medications in the long term. And find that there's a massive difference, say, between India with their Jakarta islands and accessibility and the belief system. So we go into patient and family education as being the primary way to change the outcomes.
Very short, the food is getting colder. Okay, okay. Annie Strangler from Paris here for SP. A very short comment about doctors training. Also, because it's also very important. You mentioned it, I think it's one very so evaluation of the cost of this training. Not only doctors, but wives, generalist practitioners. I think that's how we can evaluate. I mean, for the newborns, because as Michelle mentioned, the much so, but the yield of examining the patient is very, very good.
Bring to the hospital 6 children to find one that is. Okay, so maybe we have a very short break, so that's complex for everybody on the line, maybe, but we just take advantage of some lunch we have, and we are making 5 minutes between the discussion. Thank you.
And I would like to encourage the people online to come back because we really do need to have this final 15-minute discussion about agreeing